morning, friends. We're registered today to attend a heart failure support group, but we'd like to talk about heart success, function, not failure. I'm Tayyab Kumri, one of the heart success cardiologists with St. Luke's Cardiovascular Consultants at St. Luke's Mid-America Heart Institute. While this is a recorded setting, there's a chat box. If there's any questions or comments that you guys have, please feel free to put it on the chat box, and I'll be more than happy to respond to that at a later date. We'll start out with our circulatory system. Initially, the blood that is deoxygenated, that is without oxygen, returns from the body to the right side of the heart. The right side of the heart then pumps the blood into the lungs, which gets rid of carbon dioxide and gets oxygen into the blood. That's called refueling the blood. And that refueled blood gets to the left side of the heart, and the left side of the heart is responsible for sending blood with oxygen and fuel into the body. And then the body uses the oxygen and replaces it with carbon dioxide, which returns back into the lungs. When we think about a circulatory system, the main driver of the circulatory system is the heart. The heart is responsible for pumping blood both into the lungs and the body. The heart itself is like a house. It has walls and plumbing. It has doors and windows and is an electrical system. The house has different parts to its function. The main function is the squeezing function of the heart, or what we call systole of the heart. That's when the heart is contracting and sending the blood forward. Most people think about that as being the most important part and function of the heart. What we also know is that while squeezing function is important, equally important is the relaxing function of the heart, or the diastole, or the filling function of the heart. Because if the heart can't fill with blood, it can't really forward flow the blood. Again, like I said, the heart is like a house with a lot of different parts to it. And why does the heart fail? Well, the heart fails when any of that parts of the house break down. But is that really failure? No, we don't think so. We think it's a bad name, because the heart has really not failed. It's just not able to keep up with the functions of the body. So is there a definition of heart failure? Well, over the years, the definition has changed and we've used different definitions. But there's more a universally accepted definition that has been published in the medical literature these days. We define heart failure as a progressive condition in which the heart loses its ability to pump enough blood to supply the body's needs. Now, there's some objective findings that need to be associated with these that are used by the doctors to diagnose heart failure, and we'll talk about that in the later part of the presentation. So what makes our heart malfunction? Again, like I said, any part of the house may break down. The walls may become crumbly and weak, and hence it can't function and cannot eject blood, or they may become thick and hardened and may not be able to fill. The valves may get leaky and sticky and may cause the blood to not flow forward, or may cause the blood to leak backwards. The plumbing, which is the heart arteries, may get clogged up and cause heart attacks, which can lead to the heart not functioning. And last but not the least, the electrical system can either stop functioning or can start malfunctioning, causing the heart to either beat too slow or beat too fast, causing the heart to malfunction. So again, there's not one specific cause for heart failure. Having said that, what are the symptoms of heart failure? Well, the most common symptom of heart failure is swelling. Where does swelling occur? Well, swelling can occur in any part of the body. Most commonly, people think about swelling in the legs. But having said that, only 50% of the patients who have heart failure will have swelling in the legs. Some people will notice swelling in the belly. And while some people may not notice swelling in the belly or the legs, but only may note weight gain. Again, it's important to note for swelling and weight gain because those are one of the most common symptoms of heart failure. Shortness of breath is another common symptom. The shortness of breath can be at rest with exertion. Sometimes it can cause symptoms like wheezing, and sometimes it can cause difficulty laying down, which can cause shortness of breath when you lay down. Again, doctors use a term called orthopnea, a very specific symptom that's associated with heart failure. Another symptom of heart failure associated with shortness of breath is difficulty bending down when you're sitting down or trying to tie your shoelaces or leaning forward to pick up stuff from the floor. More recently, that has been identified to be a common symptom in people with heart failure. The other symptoms that are less common is lightheadedness, fatigue, and dizziness. Again, these are unusual symptoms, but sometimes associated with the medications that people take for heart failure. People can sometimes lose their appetite, get nauseated, and sometimes have racing heartbeats. More uncommonly, sometimes patients present with what we call sudden cardiac death, in which the heart stops. What are the risk factors for heart failure? The most common risk factor for heart failure is hypertension. In the United States, 1 in 4 people have hypertension, which may or may not be well controlled. Again, it's a very easily modifiable risk factor, but still very common and hence highly associated with the risk of heart failure. And we know that having poorly controlled blood pressure increases the risk of having heart failure by more than 50%. So we do believe that hypertension is the most likely and common risk factor associated with heart failure. The second more common risk factor, which is unfortunately getting more prevalent, is obesity, especially people who have what we call a body mass index of more than 30 are twice at high risk of having heart failure compared to folks that do not have obesity. In the United States, again, like I said previously, obesity is getting more prevalent and hence is becoming a more common risk factor associated with heart failure. As I said before, when heart arteries get clogged, they cause heart attacks, which can lead to heart failure, and diabetes, which is also getting more prevalent, can cause heart failure. There are other common risk factors that a lot of people do suffer from, including sleep apnea and heart valve problems that can cause heart failure. And uncommon causes of heart failure include viral infections. In the last 3 years, we have seen a lot of heart failure related to viral infections, especially COVID-19 infections, though thankfully, most of them tend to be transient and most people are able to recover from that very easily. There are other common causes, unfortunately, that are seen more commonly in the society, including use of alcohol and drugs, especially methamphetamine and cocaine, are commonly associated with heart failure. One cause of heart failure is also chemotherapy drugs, especially those that are commonly used for breast cancer. And the last cause, which is starting to get more commonly recognized, is genetic causes. In the past, we used to think that less than 10% of heart failure causes were related to genetic causes, but more recently we believe that genetic conditions are more common and may be also responsible for heart failure in the setting of other risk factors. So it's important to kind of be familiar with heart failure symptoms, especially if you have family members who have heart failure. We're talking about more about heart failure facts. One of the things we said earlier, it's a very common condition and it seriously affects patients' lives. In the United States, in people over 20 years of age, it affects about 6 million people. That's approximately about 2% of the population. And as we see in this graph, it definitely becomes more prevalent beyond 40 and 60 years of age. So much so that when we think about folks over 80 years of age, about 1 in 8 people have some form of heart failure. So it's a condition that's very common, especially as we get older. What are the other facts about heart failure? Again, 1 in 5 people will develop heart failure at some point in their life. It's also a very common cause of being admitted to the hospital, and based on the most recent data, it's the most common cause of being admitted to the hospital. It's a very expensive condition, both on a personal level and the community level, and we estimate that the annual cost of healthcare related to heart failure is about $30 billion in the United States. It does not only significantly affect length of life, but also quality of life because of symptoms of shortness of breath and inability to do things that one may like to do. Over the last several years, with a lot of advances in medical therapy, people have started living longer with heart failure, though despite that, it's a very morbid condition with about 30% of people dying within the first year of diagnosis of heart failure. Let's talk about some of the common terms that you may hear when you visit your physician or your cardiologist when you're suffering from heart failure. The most common thing that you will probably hear is the type of heart failure. And what does that mean? Well, when we talked about the sides of the heart, there was a left side of the heart and the right side of the heart. And either of those parts of the heart may get affected and cause symptoms related to heart failure. And that leads to the diagnosis of left-sided heart failure versus right-sided heart failure. The other thing that happens, like we said before, is the squeezing function of the heart may become abnormal, or the relaxation function of the heart may become abnormal. When the squeezing function of the heart becomes abnormal, we call it heart failure with reduced squeezing function or reduced ejection fraction. And when the relaxation function of the heart is abnormal, but the squeezing function is normal, we call it heart failure with preserved squeezing function or preserved ejection fraction. So when you look at your medical charts, you may hear the term HFpEF or HFrEF, which again is determined based on the squeezing function of the heart. The other thing that people may talk about, like you said, is the left side of the heart. As we said, there's about weakened functioning of the heart and the stiffening of the function of the heart. And this happens about 50-50%. And unfortunately, while people may think that people with the weakened heart muscle are likely to do poorly, what medical literature and science has shown is that people with either a weakened or preserved heart function who have symptoms of heart failure do equally poorly when looking at long-term survival and quality of life. The other thing that you will commonly see is classes of heart failure. Now, your physicians and heart doctors will use these to determine what are the medications that are appropriate for you and what other interventions need to be done to improve your survival and quality of life associated with heart failure. The most commonly associated classes or stages of heart failure are defined by the American Heart Association and American College of Cardiology, and they go from stage A to stage D, in which folks who are at risk of heart failure but don't have any heart function abnormality or symptoms of heart failure are called stage A. Stage B are those who have structural abnormalities but don't have any symptoms of heart failure. And stage D and C are those who have varying severity of symptoms associated with heart failure. While this is a linear progression of heart condition between patients who have risk factors of heart failure, and there's another classification of heart failure called New York Heart Association classes of heart failure, and they go from stage 1 through 4 based on the severity of symptoms, from minimal symptoms to severe symptoms. In this classification, though, patients can go from mild symptoms to severe symptoms, but then with treatment can come back to a lower class. So this is another common terminology that you may see when either looking at your records or when discussing your symptoms with your physicians. The most commonly seen or heard about terminology when patients have heart failure is what we call ejection fraction. So let's define ejection fraction. When we think about the heart as a pump, the heart doesn't eject all the blood that's in its chamber. There's some amount of blood that's left at the end of the squeezing function of the heart. And the ratio of the total amount of the heart blood pumped versus the amount of fluid in the chamber at the beginning of the squeezing function is what's called ejection fraction. What is the normal ejection fraction of the heart? Well, the normal ejection fraction of the heart is anywhere from 50 to 70%. When we think about mildly reduced ejection fraction, it's 41 to 49%, and moderate to severely reduced heart function is less than 40%. Most people think that ejection fraction is the be-all, end-all about how bad your heart failure is. And this used to be the thinking 20, 30 years ago. What we clearly know now is that this is only a small part of the story in people with heart failure with both preserved and reduced ejection fraction, because the heart can compensate even in the setting of reduced heart function in a lot of patients, and even patients with significantly reduced ejection fraction may have very good quality and quantity of life. When we talked about diagnosis of heart failure, we did say that not only are symptoms important, but there's some testing that goes along with it to define heart failure. And not only define heart failure, but to quantify the severity of heart failure. So when you see a cardiologist, what are the testings that you should expect? And another question is what are the things you should expect at an appointment when you see your cardiologist? The first thing your cardiologist will ask you about is your symptoms of heart failure. And like we talked about, the symptoms that he's going to talk to you about is shortness of breath, swelling, whether it be in your belly or legs or any other part of the body, difficulty of laying down, changes in weight. The other thing he's going to ask you about is your blood pressure, if you have been routinely checking your blood pressure. And the last thing they will ask you about is how far you can walk, because that is what they use to define the severity of your symptoms. When you're in the doctor's office, they will check your blood pressure and they'll get an EKG on a regular basis. They'll also do a physical examination to look for signs of excess fluid. They'll commonly look at your neck and while you're laying back a little bit to define the amount of fluid that you're retaining. This is what the doctors are looking at, is your jugular vein and assessing the amount of fluid that the heart is retaining. They may also get some heart imaging testing that we're going to talk about a little bit more. The heart doctors may then prescribe medications depending on what they feel your fluid retention levels are, your blood pressure is, and depending on what the test results show. And in some cases, if you have low oxygen levels, they may recommend potential use of additional oxygen. The other thing that the doctors will routinely talk about is lifestyle modification. This is very commonly done when you see and visit with your physicians. And this is not true only in the heart doctor's office, but in any practitioner's office. They'll be talking about restricting diet, including restricting sodium, restricting the amount of fluid, increasing your activity, and avoiding substances like tobacco, alcohol, and other heart-stimulating and heart-damaging substances. The first and most commonly done test is blood work. This is routinely done, and the doctor is looking for your blood counts. The reason for that is if you're anemic, this can put more strain on the heart and can cause your heart failure to get worse. They're also looking for your blood sodium and potassium levels because medications that you take for heart failure may affect your blood sodium and potassium levels. And they're also looking for kidney function and thyroid function because those can get affected by heart medications. Also, making sure that you have normal thyroid function is really important to optimize your heart status. The other specialized test that they may do with blood work is looking for a blood marker called troponin and a blood test called BNP. These are blood tests that are used to assess for heart injury or to assess extra fluid levels in the heart. Heart doctors will also get x-rays of the chest to look for heart enlargement and to look for your lungs and to see if there's a fluid retention in the lungs called pulmonary edema. Unfortunately, chest x-rays, while done routinely, may be not as useful as we think as maybe because only about 20% of people who actually have fluid retention in the lungs will show abnormal chest x-rays. So don't be surprised if the doctor reports that the chest x-ray was normal, but you are having significant symptoms of shortness of breath related to fluid retention. Electrocardiograms are commonly done in the hospital and the offices in patients with heart disease. They're very basic tests that have been around for more than 100 years, and it looks at the spark plug of the heart and the electrical cables of the heart. As we said, abnormalities of these functions can be either responsible for heart failure or in people who have significantly abnormal heart disease can have abnormalities develop in these systems. The more advanced testing that we're going to talk about that is done to assess your heart in a more detailed fashion is called an echocardiogram, more commonly called an echo. This is an ultrasound of the heart. An ultrasound is a test that most people are very familiar with. It's a test that the doctors will prescribe in pregnant women looking for babies, or if you have a gallbladder issue, looking for gallbladders, or looking at a kidney for kidney stone. But this is an ultrasound done for the heart. It's done using a special probe that is put on the chest wall with a cold gel between your chest wall and the machine. And they're able to look between your rib cage and look at the heart through different angles. And that's able to assess the squeezing function of the heart, the relaxation function of the heart, and is also able to assess the function of the heart valves. While this test is very comprehensive, unfortunately, it cannot look for blockages in the heart arteries or look for abnormalities in the electrical system of the heart. We do more testing to look for blockages and other causes of heart failure, including tests like a stress test, which looks for blood flow in the heart. We tend to do MRIs, which are very specialized tests looking for abnormal function and cause of the abnormal function of the heart. And in some cases, we do recommend doing heart catheterizations or coronary angiograms to look for heart artery blockages and sometimes looking for severity of fluid retention in the heart. As we said previously, genetic testing is becoming more common as we identify more and more people with heart failure. Again, when we offer genetic testing to the patients, it's really important to receive counseling about the social and societal impact of genetic testing because there may be unexpected implications of the results of the genetic test. The way this is done is by using a salivary specimen that is sent out and it comes back with the results of the genetic test. It's not all-encompassing. As time goes by and as our knowledge about genetic abnormalities continues to expand, we typically recommend that this test may be repeated every 5 years to look for specific mutations that may have been identified more recently. How do we treat heart failure? The first and most important thing to remember is when treated well, people with heart failure can live normal lives. When people have heart failure, again, our focus is to be successful rather than think about it as failure. There are several medications and devices that are now commonly used to prolong life, improve symptoms and functions and quality of life, and also improve the functioning of the heart itself. Again, the goals of treatment are in the order presented here, with the most important goal being improving life survival, the second most important goal being to improve symptoms and to reduce the risk of being admitted to the hospital, and if possible, also improve the function of the heart. While the doctors will prescribe medications, it's very important for you to be changing your lifestyle, eating healthy, regularly exercising, and trying to lose weight. So how do we treat heart failure? Well, again, like we said, there's different causes for heart failure, and those usually are treated with different medications. What we try to first treat is the underlying cause of heart failure. So if blood pressure is the cause of your heart failure, we try to control the blood pressure. If abnormal valve function is the cause of your heart failure, we try to address that. And if coronary abnormalities are the cause of your heart failure, we try to go and fix those blockages. It's very important to also treat the risk factors that we'll talk about in a little bit. The most commonly prescribed treatment in patients with heart failure is water medicines, or what we call diuretics. Commonly known medications include Lasix or furosemide, Demodex or torsemide, and Bumex or bumetanide. These medications are used a little bit interchangeably, but furosemide is used most commonly in patients who are less sick, and the latter two medications are used in people that may be more refractory to furosemide. What are the medications most commonly used in people with weakened heart muscle? There's a long list. There are primarily 4 medications that we believe are the pillars of treating people with a weakened heart muscle. We're going to start with medications, and we're going to start with a medication that was first identified to improve survival in patients. This is a group of medications called ACE inhibitors. The common drugs that are ACE inhibitors end with the term pril, and the most commonly used drugs are lisinopril, enalapril, or ramipril. The way these medications work, they relax the arteries of the body and hence makes it easier for the heart to pump blood. They improve survival by about 25 to 30%. Again, these have been around for more than 30 years and are used very commonly. One of the most common side effects to remember about with this group of medications is a cough. They call it dry cough, which can occur anytime after initiation of medications. Sometimes it occurs soon after starting medications. In some people, it can occur after being on the medicines for years. So if you start experiencing a cough that cannot be explained, make sure you discuss this with your doctor and see if you're on this medication. And if that's the case, there are alternatives that we won't talk about. The other side effect that is uncommon but can be life-threatening is angioedema. This occurs specifically in this group of medications, more commonly in the Black population, and is associated with swelling in the lips or the tongues, which can sometimes, if not treated, cause difficulty breathing. In patients that cannot take ACE inhibitors, there's another group of medications called angiotensin receptor blockers, or more commonly called ARBs. And the medications most commonly used for that are valsartan or Diovan, candesartan or Anacan, and losartan. Again, these are medications with similar benefits like the previous group, except they don't have the cough and the angioedema side effects that are associated with ACE inhibitors. The new kid on the block is a medication that's been available for the last 10 years. The brand name for that is called Entresto. It's a combination medication that uses valsartan along with a special drug called sacubitril. And for the first time in 20 years, it actually showed that there was a drug that was better than ACE inhibitors. It has almost all the same side effects as ACE inhibitors, but the symptoms of cough and angioedema are less common. Again, it's very important to remember that this is an alternative to ACE inhibitors or an alternative to ramipril, enalapril, or lisinopril, and should not be used simultaneously with these drugs. The unfortunate thing about these new kids on the block is that they tend to be a little bit more expensive and difficult to get, and sometimes we need to work with the drug manufacturers to see if we can get some patient assistance and medication samples. Another old kid on the block is beta blockers. They've been around for more than 20 years. The most commonly used drugs are carvedilol or Coreg and metoprolol or Toprol. The way these medications work is they reduce the stress on the heart being created by the adrenaline released by the body. And by reducing the stress on the heart, they allow the heart to recover function. They also tend to reduce your heart rate and blood pressure, though unfortunately they can sometimes be associated with fatigue. What I describe to my patients is that it feels like somebody put a brick under the gas pedal of your car. When you try to rev the engine, it's just not happening. And thankfully, these side effects tend to be short-lasting in majority of the patients, and most of the patients can tolerate this medication over time. And actually, as the heart function improves, the symptoms of fatigue may improve. This is another medication that's been around for more than 20 years, called aldosterone blockers. These medications are believed to reduce the scarring within the heart muscle and allows improvement in functioning of the heart. They also tend to be weak diuretics or weak water medicines that can augment the function of the diuretics we talked about earlier. We have to be careful when you take these medications, especially in combination with the other heart medications, since they can potentially cause life-threatening increases in blood potassium levels. And when being started on these medications, your doctors will routinely check blood work on frequent periodic intervals to assess for blood potassium levels. It's very important to be careful when you start taking this medication with the previous group of medications, especially the ACE inhibitors and the ARBs, because a combination of these medications can cause life-threatening increase in blood potassium level. So it's very important to make sure that you stop taking your potassium supplements that you may be taking over the counter and be on a low potassium diet that can be discussed with your physicians. Another uncommon side effect of spironolactone is breast enlargement, especially in men. It's uncommonly associated with breast cancer, but if you do develop breast enlargement, then we can change you over to alternative medication with eplerenone, which is known to have similar benefits of spironolactone. The last kid in the block, which has been around for the last 2 or 3 years, and probably most commercially recognized because of marketing from drug companies, are SGLT2 inhibitors. The most common drugs in this group are Farxiga, Jardiance, and Invokana. These drugs were initially designed to be diabetic medications, but more recently we have identified them to be highly useful medications in people with heart failure with weakened heart muscle. They also act as mild diuretics and cause some weight loss, which are also very beneficial effects of this medication. Unfortunately, like Entresto, they are newer and tend to be expensive and difficult to get. Less common side effects of this medication are genital yeast infection or urinary tract infection, especially in women, which occurs in less than 1% of patients. and can be treated with over-the-counter or prescription medications. In patients that cannot tolerate the last 4 groups of medications or continue to have symptoms despite being treated with all 4 groups of medications that we discussed previously, second-line drugs that can be used to improve symptoms or heart failure include digoxin, which is a medicine that's been available for centuries, a combination of medicine called hydralazine and isosorbide, which is very inconvenient to take since it's 2 medications taken 3 times a day. And the other 2 medications, both ivabradine, which slows down your heart, and vericiguat, which is a new medication that relaxes the arteries in your body, which tend to be highly expensive. Unfortunately, while we have a lot of treatment options in patients that have a weakened heart muscle or weakened squeezing function of the heart, the treatment regimen is more restricted in people who have stiffening of the heart muscle. We believe that part of the reason may be that in those patients, it's not just a heart problem, but there may be other issues that may be happening at the same time, which makes it more difficult to treat. The primary focus in these patients is to try to remove the extra fluid in the body using diuretics with the same medications that are used previously described, including furosemide, torsemide, and bumetanide. There is some newer data that shows that the newer drugs with Jardiance, Farxiga, and Invokana may be helpful in this group of patients to improve their risk of hospitalization and to improve their quality of life. There are some special conditions that do cause stiffening and thickening of the heart, including a condition called cardiac amyloidosis and hypertrophic cardiomyopathy. In the last 5 years, there are new targeted medications that have become available for these specific conditions that have been associated with significant improvement in both survival and quality of life. The important thing about these medications is we tend to start them slow and gradually increase the dose of the medications. Sometimes as a patient, this can be very frustrating because every time you go to the doctor's office, there's an increase in the dose of the medication or the addition of an extra medication, or the doctors are being pawns to the pharmacy industry. But that's not the case. The reason that these medications are started slowly is because they do tend to reduce your blood pressure and can have serious side effects if you start out at higher dose. Be patient with your doctors. Stick with your medications. Even if you do have some side effects in the beginning, try to stick it out, because if you do tolerate them, they are associated with significant improvement in survival, improvement in quality of life, and also improvement in heart function. The one thing that's really important in patients who do suffer from heart failure is trust and communication with your heart failure. I personally believe that if you do not have trust with your heart doctor or your physician, you need to find an alternative physician, because without that trust, you will not get better. Besides medications, what else can be done? We recommend exercise or cardiac rehab in most patients with heart failure. Unfortunately, while this is currently only approved by insurances in people that have weakened heart function, we do have data that it's useful in people with all forms of heart failure. Why does exercise help? It improves muscle tone, it improves bone mass. It is able to allow your heart to be able to get the function done with less energy consumption. What level of exercise is recommended? Well, we recommend doing about 30 minutes of aerobic exercise 5 days a week for a total cumulative 150 minutes a week. The advantage of formal cardiac rehab referral, which is usually recommended with 12 weeks of exercise sessions 3 days a week, is also a good time to be able to get more education about heart failure and also have shared experiences with other patients that may be suffering from similar symptoms, along with getting the benefits of exercise. How else do we treat heart failure? Like I said, we treat the underlying conditions and we also treat the underlying risk factors. Anemia is very important to treat, especially if you're deficient in iron. More recent data shows that iron pills are not very useful, and we should treat people who have iron deficiency with intravenous iron. This is really important because a lot of people who have heart failure also take blood thinners because of heart artery blockages, which can cause blood loss, and hence we routinely check for blood levels of iron and replace those with intravenous iron. Sleep apnea is a very common risk factor for heart failure and causing dangerous heart rhythm issues and should be evaluated and treated appropriately. The most common treatment for sleep apnea, unfortunately, is CPAP therapy, which unfortunately is not very popular or commonly tolerated. But it's important to get yourself evaluated and treated appropriately. Lifestyle modification, including working on obesity and smoking, is really important to help get over symptoms of heart failure. Unfortunately, giving up smoking is not that easy. There are different philosophies on how one can be successful in quitting smoking. Some people believe that we can gradually wean off smoking. I personally believe that the only way to quit smoking is to quit. There are some prescription medications that can be used to help quit smoking, though the efficacy of these medications is not very high. The important thing when people are asked to quit smoking is the motivation that one has to quit smoking. It's really important to be motivated. In the absence of motivation, quitting smoking is very difficult. The other thing that we are starting to identify more commonly in people with heart failure is depression. Part of the problem with depression is depression and heart failure have shared symptoms, and hence is very hard to identify and sometimes underappreciated and undertreated. About 1 in 5 people with heart failure are identified to have depression. Again, like we said, they commonly have shared symptoms, including lack of energy, lack of appetite, and inability to enjoy yourself. Unfortunately, depression also causes worsening of heart failure, since a lot of people treat themselves and treat their depression by smoking and using alcohol, and also eating unhealthily. There are better ways of treating depression. Regular exercise will not only help with depression, but it helps with heart failure. Controlling your medications is really helpful. One of the heart medications is associated with depression, and one has to be careful in people who have depression. There are also medications that can prescribe for depression, and it's important to talk to your doctors about that. While medications are associated with improvement in survival and quality of life, unfortunately, not everybody responds equally to medications, and there are certain more implantable devices that can be used to treat heart failure. One of the most common devices that are recommended for people with reduced ejection fraction heart failure are defibrillators. These are pacemaker-like devices that are implanted in people at risk of sudden cardiac death. Sudden cardiac death is a condition in which the heart goes into an abnormal, very fast heart rhythm in which the heart stops beating and the person dies. A defibrillator is a pacemaker-like device which is watching every heartbeat, and if it detects a dangerous heart rhythm, it will deliver a shock to the heart to try to reestablish a normal heart rhythm. Important things to discuss when a defibrillator is offered to you is whether this is something that is important to you. Defibrillators improve survival but do not improve quality of life. And in people who have a chronic debilitating condition, survival is not necessarily the most important thing and the be-all, end-all. If your goals of care are different than just improving survival, this may not be something that you may want. Another important device that can sometimes be offered to patients who have a specific electrical abnormality in the heart called a left bundle branch block is called a biventricular pacemaker. This can commonly be combined with a defibrillator, and in this case, we place a wire in the right side of the heart and the left side of the heart and try to pace both the sides of the heart simultaneously to improve the efficiency of the functioning of the heart. This, unlike a defibrillator, is commonly associated with significant improvement in the heart function, improvement in survival, and improvement in quality of life. And about 2/3 of the patients that receive this notice significant improvement in their heart failure. More recently, we have developed ways of monitoring your heart failure severity with implantable devices. A device called a CardioMEMS device can be implanted in the left side of the lung that monitors the fluid levels in your lungs, and this data can be used to treat the severity of fluid retention. There are newer devices on the block that may be available in the next 2 to 5 years, including a device called a cardiac contractility modulator and a baroreceptor stimulator. Again, these devices are more in the developmental phase and clinical research phase, while they are FDA approved for heart failure. While we talked about what the doctors can do for you, the most important thing as a patient is to live with heart failure. And as I said before, when you hear the term heart failure, we want you to think about success rather than failure and try to live with heart failure rather than dying from heart failure. Self-management with heart failure is really important. The biggest thing that causes exacerbation of heart failure is excess salt. Salt acts like a sponge and causes fluid retention in the body, and hence we definitely want you to restrict sodium consumption. We routinely recommend less than 2 grams of sodium in the diet. This can be very difficult since a normal North American diet contains 6 to 8 grams of sodium a day. The best way to avoid excess sodium in the diet is to avoid processed foods. What I tell my patients is eat food that the Lord made. Lord did not put salt in the diet. Lord did not put salt in the food we ate. Only after man got their hands onto the food did we add salt to the food. Again, read labels when you buy food. Be careful about the amount of sodium you get in a meal. Along with sodium restriction, monitoring your daily weights and blood pressure is really important. If you have significant weight gain, reach out to your doctors. Usually your doctor will develop a plan in which you can adjust your water medicines when you gain weight. And the last thing, like you talked about, is regular exercise, 30 minutes a day for 5 days a week for a total of about 150 minutes on a weekly basis. The last thing, unfortunately controversial in the last several years, is vaccination. We do strongly recommend that everybody who suffers from heart failure get vaccinated for influenza, pneumonia, and COVID-19 infections. While we do recommend that blood pressure be monitored on a regular basis, how should you check your blood pressure? We usually don't go into the details of how one goes around checking the blood pressure. Unfortunately, blood pressure can be highly labile, and it's very important that we check blood pressure at the same time of the day, every day, so that we get a consistent log of our blood pressure. When you want to be checking your blood pressure, make sure you are sitting in a chair in a comfortable position with your back well supported, with your legs uncrossed, and be resting there for at least 5 minutes before you start checking your blood pressure. Make sure you've emptied your bladder and bowels before you go checking your blood pressure. Make sure you've not had any coffee in the last 30 minutes or have not exercised in the last 30 minutes before you check your blood pressure. We recommend using a blood pressure cuff that's used in the arm rather than the one on the wrist. It tends to be more consistent and accurate. We usually recommend obtaining 3 readings and then using an average of those 3 readings for blood pressure monitoring. Also, make sure you've not had any alcohol before you check your blood pressure and is not using any smokes, not been smoking before you check your blood pressure. Besides lifestyle modification, it's very important to track your symptoms. The American Heart Association on its website has a self-symptom plan or symptom checker plan that can be used. And as long as you stay within the green zone, you're okay. If you start slipping into the yellow or the red zone, you need to seek medical care, including reaching out to your cardiologist or physician for more recommendations or seeking emergency room care. As we discussed previously, there's a lot of medications that are available to treat heart failure. It can get very confusing. It's very important that you have a list of your medications with the specific reason why you're taking the medication, the dosage of the medication, and how frequently you take it and what time of the day you take it. People keep these records differently. Some people keep it in a book. Some people keep it in binders. But it's really important to make sure that you have this list. Every time you visit your doctor's office, you should receive a list of medications with specific instructions and reasons why you're taking those medications from the doctor's office. There are several apps available on smartphones that can help improve your medication compliance. These not only put in reminders for you to take your medications, but also help you time your medications and keep information about medications that you take on a regular basis to help improve medication compliance. We've talked about what the doctors can do for you and what you can do for yourself for heart failure. But while you're doing all this, it's also important to define the goals of life and goals of care when living with heart failure. As we said in the definition of heart failure, it's a progressive condition, and unfortunately, a lot of patients do succumb to heart failure. Like we talked about, a third of the people who have heart failure die within a year of heart failure. And it's very important to define your goals of care. We want to make sure that you have talked to your loved ones to clarify what your goals of life and goals of care are when being treated for a chronic condition like heart failure. Not only is it important to talk about this at the beginning of your diagnosis, but also talk about it intermittently, since your quality of life may have changed and your goals may change along the course of the disease. The other thing we highly recommend for all patients, including patients with heart failure or patients who suffer from chronic medical conditions, is to identify a durable power of attorney for healthcare. This is really important in case you suffer from a condition in which you are unable to make decisions for yourself, because this person will then be able to be your surrogate and make decisions according to what your wishes may have been. The last thing is, every time you see your doctor, besides trying to identify what else the doctor can do for you, there are certain questions that are worth asking, especially when you're being taken care of in a facility like St. Luke's Hospital. The first question to ask is, are there any new clinical trials available for me to participate in? This is really important because there's ongoing clinical research in different ways of treating heart failure. And while this may or may not help you individually, this does allow advancing the field of heart failure. And the last question to ask in people, especially who may have advanced heart failure, is whether they are candidates for a heart transplantation or a device called a left ventricular assist device, which is a heart pump which replaces the function of the heart. In patients with advanced heart failure who may want to pursue additional therapies, it's really important to ask these questions, especially if they are having recurrent heart failure hospitalizations or life-threatening abnormal heart rhythms. In summary, like we talked about, it's important to be familiar with your symptoms of heart failure, get appropriate testing, make lifestyle modifications, including monitoring your weight, blood pressure, and dietary changes, along with exercise. It's very important to quit smoking and alcohol. And the last but not least, it's important to try to reduce stress in your life and define the goals of your care when patients are living with heart failure. While we did call this heart failure, like we said, we want to think about it as heart success, and we do not want to let failure get to your heart. There are a lot of community resources available for people with heart failure. There are several of these listed on this page, and feel free to use them. Thank you again for attending this heart failure educational seminar. Again, what we talked about is a very short summary of everything that we have and can do for people living with heart failure. Feel free to reach out to us with any questions regarding yourself or your loved ones who may have heart failure or may have symptoms that are concerning for heart failure.